Dear friends and colleagues, greetings from Morocco. I would like to thank the organizer for inviting me to the summit to share with you my insight on affordable new innovation in urology. I have no disclosure, but first I would like to invite you to submit your work to a competition called Bantuk in a session that held the first day of SIU. It will be the 23rd of October, 2024. And the competition is called Bantuk, Best Affordable New Technologies in Urology Contest. The deadline for application is the 31st August. Here are the winners from previous years. And you will find the rules on the SIU website. So why do we need affordable innovation when things are not available because there's a lack of money, poor organization, or slow motion administrative hassle? So what do I do to have cheap alternative? Is being ingenious, open-minded, is optimize what I have in hand. And don't forget that necessity is the mother of all invention. But most people, when we talk about innovation, they think about object or device. But the cheapest resources and innovations are idea, techniques, optimization, what we have, organization, communications. And I will try to give you some example on each of these ideas. So Jonathan Swift had said, vision is the art of seeing things invisible. So we have to have this vision. Let's start by talking philosophy. So in our courses and our discussion in meetings or in universities, we are stating that this or that technique is difficult. And I will take the example of PCNL. So some student, resident, or colleagues are afraid to even try it. So what is easy and what is difficult? That is the question. So in my point of view, difficult is something inhuman, like flying like Superman or run like Flash. Perhaps I will agree with you with world-breaking records, like jumping from the stratosphere. So what is easy? What is easy is what many people are doing. If a human being has done something in the past or can do it in the future, it is easy. But most people mistake easy to do, but needs a lot of work to achieve a lot of precision, carefulness with difficult. I will give you an example. Is it easy to climb 10 stairs compared to 1,000 stairs? Many people will say that 1,000 stairs are difficult, but we're talking about the same technique. There is no difference. Only with 1,000 stairs, you need more of time, more dedication. So is PCNL difficult? I will take the analogy of crossing the street. Is it easy? Most people will say it is easy. But I don't think so. When would you let your child cross the street unaccompanied? At 6 years? 10? Even more in some African countries when the traffic is intense. So it needs long years to learn, coaching and accompaniment. You have to take his hand. You have to be precise, rigorous skills, and be careful because there are a lot of complication, bleeding and death. So is the class half full or half empty? So instead of saying, beware, the PCNL is difficult, it is better to say PCNL is easy, but needs learning time longer than open surgery, precise, rigorous skill, and coaching and accompaniment. So I have the opportunity to do few workshops in Africa, and in Africa we have to innovate. I was in a workshop in Mali in 2022, and we didn't have something to protect our clothes, and I have the irrigation fluid into my feet. So I had the idea to use this glove, and now every time I don't find the things, I use the gloves. So we have devised a model for learning nephron-sparing surgery. Here the irrigation with the blue dye, and we take a lobule as a tumor. We begin by electrosurgery, cautery, and then we continue by blunt dissection like we do in real cases. Here there is bleeding, and at the end of the tumorectomy, the help will close the parenchyma, helping closure of the parenchyma. TRP model. So we use sheep kidney. We inserted it into a glove, and we use bipolar saline resection. So it is like a regular resection, and we have the real tissue feeling. The chips goes into the palm of the glove. And we can upgrade this model like the previous one by doing irrigation. So for percutaneous calyceal puncture, we use a glove filled with saline and into foams and contrast media. And we use the tip of the finger as calyx. However, this model is limited when it needs SARM radiation exposure. I was thinking for many months how to use only light. And I was in a workshop in a university hospital in Marrakesh, and they have this retroprojector. So I think this is the one, and we use a glove filled with air. Another time, I was with the small groups of urologists, and we didn't have this retroprojector. So we have the idea to use the torchlight application of smartphone, and we can shorten the fingers of the glove, and it is like hydronephrotic kidney. I use it in all my workshops. For tract dilation, the best is a watermelon model here in Douala in Cameroon. And it was winter in Morocco, and it is difficult to have watermelon in winter. And I have the idea to use a small piece of this pumpkin and into a glass jar to see the progress of dilation. And we can use other squash. And also in 2019 in Eris, we have experimented with different vegetables, eggplant, and the best one is the one with hard skin. So I was in Dakar, and they have this 25 French nephroscope, and it needs a higher amplathe sheet. We wanted to use only 22, so we have the idea to use the piece of the rigid ureteroscope from Olympus and to close the whole of the irrigation with the small piece from a glove. Thus, we were able to work with only 22 French amplathe sheet. So you have an obese patient and you need a long amplathe sheet, and you don't have it. I don't like the technique in which we push the amplathe sheet into the subcutaneous tissue. So what I do is I insert the working amplathe sheet into a larger one, and thus it is very long, and we cut it to length as the length of the nephroscope. And here the introduction of both amplathe sheet. Alternatively, You can use a longer drinking straw. So it was the end of PCNL, mini PCNL with the 14 French en plate sheet, but we cannot introduce a Foley catheter of the same diameter. So what to do? So we had this idea to introduce the rigid side of the guide wire, and the catheter is stretched over it and fixed with the forceps. And this long catheter is now easy to introduce. Into the 14 French en plate sheet. So I always recommend the insertion of safety guide wire. One of the techniques I use is using a small segment of the coil housing the guide wire. Here, the endoscopic view. We use other techniques through the en plate dilator or outside the fascial dilator, but mostly we can use also an aspiration or feeding tube. Another technique to have safety guide wire or without safety guide wire is to use the principle of the parallel axis ureteral axis sheet. So the guide wire is inserted in just a small segment of the ureteral catheter or the WG pusher, and by inserting the dilator, it will push the wire outside. So at the end of the procedure, the working guide wire is outside the en plate sheet. So in a very mobile kidney pushed by the dilators, we stop the en plate sheet just outside the kidney here, outside the gyrostas fascia, and by the P-prong forceps, we open the parenchyma until we reach the stone or the calyx. This technique, I use it in all my PCNL workshop to give confidence to the attendant that if you have a problem during dilation, you can continue endoscopically. So to optimize what we have at hand is equipment multi-use. So since 2003, I was using the rigid ureteroscope as a second access if I need it. So here progression in the retroperitoneum, and we find the stone and we push it toward the pelvis and it will be extracted by the nephroscope. This is the second indication of the use of drinking straw. If we don't, in mini PCNL, if we don't find a proper or smaller en plate sheet, and here using the rigid ureteroscope, we can do mini PCNL. So I was doing mini PCNL. I needed a nitinol basket. I only had a larger one per circle. So what to do? So we opened the basket and we insert the inner insert of the basket retrogradely, and we were able to use it for extraction of the stone. Do you know what is the real extra shockwave lithotripsy? So in last May, I was in Conakry and we had this large stone with multiple stones in the lower calyx. We could not remove them with the basket. So we had the idea to do extra shockwave lithotripsy, and we managed to remove multiple stones, more than 40 or 50 small stones. So we were doing PCNL, and at the end of Staghorn calculi, and we have this small fragment, we could not dislodge it with aspiration or irrigation. So I needed a nitinol basket. I didn't have it. So we used this floppy hydrophilic guide wire to do a basket, and we were able to remove the stone. So pushing the idea forward, is it possible to do a basket from another equipment or material that we have in the operating room? So we here with the nylon suture, and here in the left trying it on in our endoscopic glove model, and here in a real patient. Can we use it for the rigid ureteroscope or the flexible ureteroscope? Yes, we are working on it. So during PCNL, I was in a workshop and we wanted to do percutaneous endopuloplasty, and we had this suboptimal vision with bleeding in the renal parenchyma. So we wanted to do a coagulation of the tract, but we didn't have a proper electrode. So we used the metallic membrane stellate of the ureteral catheter to do the coagulation. Here, before and after, and you see that you have really good vision with no bleeding. We can use this same electrode to do bladder neck contractor or endopulotomy or endoureterotomy. Alternatively, if you don't have this this catheter, you can use a basket. Here it is a nitinol basket, and you can apply the electrocautery on the screw. Alternatively, we can use a hydrophilic guide wire as an electrode, and here we use here in mini PCNL, we had the large venous bleeding and coagulation of the endoscopic tract of the parenchyma. Also, we can use the same guide wire electrode through a flexible ureterorhinoscope. And here we are doing retrograde endopulotomy with this makeshift electrode. So, George Bernard Shaw had said that progress is impossible without change, and those who cannot change their minds cannot change anything. So we have really to change our way of thinking to progress. And don't forget that until now, all the evidence are showing that Africa is the cradle of humanity, and the first technology and first affordable innovations are Africans. So my take-home message is promote unstressful supervised teaching and learning. And don't forget that the glass is half full. So all the techniques are easy. And we have to do to gather a large knowledge of technique, tips and tricks, and how to overcome difficult situations. We have to cultivate this idea and tricks and share them and coach and share resourceful habit. And I will quote Bob Marley: we have to emancipate ourselves from mental slavery. None but ourselves can free our minds. So we have to emancipate ourselves from bad history, from bad paradigms and dogma. And I have many videos on my YouTube channel, and I thank you.